Viewer saying, would Medicare gain from the enrollment of younger people who are presumably healthier?
Well, they won't be enrolling in Medicare, but obviously it helps the entire system if you have people who have health care coverage through their entire lifetimes. There have been studies that have shown that when people who are within the last decade or so of Medicare eligibility, say in their mid to late 50s, if they end up losing their health insurance coverage, they cost the Medicare system significantly more in the first 5 years that they turn 65 and are eligible to join Medicare than the people who have insurance in that last decade. So it does make a difference to the Medicare program if you have someone who's been healthy their entire lives because they've had regular checks, preventive care, all of the normal things that are associated with having insurance coverage.
Joy is joining us from Los Alamitos, California. Good morning, welcome.
Hi there. I hope I can make these 2 points really, really clear.
Sure.
The very first one I want to make is the so-called Obamacare has absolutely nothing to do with the health care of our American people. It has everything to do with Obamacare wanting to take power and control over this country and all of our lives. Second point I want to make is I'm 78 years old, fortunately very healthy. But I have a retiree plan that I worked 40 years of my life for. So I made sure that I have a Medicare plan. Fortunately, it's a retiree plan. I'm very lucky. But now the so-called Obamacare will take it away from me. I will no longer have this great medical plan that I worked all my life for, so they can give it to those people who have chosen not to work as hard as I did. And the third, most important, my father, I'm still spending 5 years for what they did to him in Toronto, Canada. He went up there to visit. Unfortunately, ended up in an emergency room. He was 89, but healthy as a horse. Because he was 89, he was delivered by emergency ambulance with a simple hematoma that was bleeding in his head, but he was delivered at 8:30 at night. In Toronto, Canada, they are allowed 13 surgeries a day. This is a major hospital, the second major hospital in Toronto. So there was no surgery to be done on my father at 8:30 at night. So what did they do with him? They put him off in a corner where all my phone calls all night long, nobody knew where he was. He gradually, that hematoma kept on bleeding to where he ended up nothing but the next morning a comatose human vegetable. Too late. I'm now, as his adoring daughter, had to have him put to sleep. Because as active as he was, I knew he would not want to be left like that. That is universal care in Canada.
Joy, when did this take place? What year?
5 years ago.
5 years ago.
Right, okay. And I'm still fighting. I've been with their legal communities up there, which I still am. I've been with their so-called College of Physicians and Surgeons and their appeal board. I've been to 2 of their meetings. And all they do is they decide to refer to my dear father, who was, what did they refer to? A demented old man who did not survive. Now, I had just put my father on a plane 3 days before this happened. He was going up there for a family function, but he had a headache. And I also have a consultant here in California that I sent all the records to. The simple hematoma that had been taken care of when he was delivered. Oh, he was delivered under 4 doses of morphine.
Joy, I'll stop you there. Thank you for sharing your story with us. We'll get a response.
Well, I'll try to see if I can hit all of 3 of the points as quickly as I can. I guess first, I'm very sorry about your loss and what happened with your father, and I congratulate you for your good health that you said that you have. First issue was the issue of control. In fact, you can question whether or not the health care bills that are currently being considered by Congress are actually where the president had initially started when he was proposing health care during the campaign, but in fact, the administration has been working very closely with them as they have tried to find middle ground. There is no government control in these plans, and currently those decisions are being made by insurance companies. It's not as though the current system, all decisions get made by doctors and their patients. What happens is the insurance industry has a great deal to say about whether or not a particular procedure is going to get covered, how much it's going to get paid, whether you're even going to be able to buy a policy. So people, I think, start out with the assumption that the current system is all about control between patients and doctors, and in fact it isn't. There's a middleman there. It's the insurance industry, and they're the ones that are controlling. It's issue number one. Retiree costs, I'm thrilled that you have a retiree plan. There are actually incentives in here to try to make sure that employers don't dump those plans. Historically, they have been eliminating their retiree coverage or curtailing it for decades. They do end up doing more cost shifting, particularly in the last 5 years or so. We have seen a dramatic increase in the amount of cost shifting and a reduction in benefits. These bills are an effort to try to maintain that system, and especially if you can reduce costs, then there's more of an incentive for employers to keep those plans.
Let me follow up on that point.
Sure.
This morning that they expect the CBO numbers, the Congressional Budget Office, on this latest plan to be out sometime this week. Any speculation or prediction?
Well, I would be surprised if there were a lot of big surprises. Usually there's back and forth that happens between the members as they're designing these proposals and the CBO. You don't get a final score until they work out all the interactions, but you do have some expectation at least that you're going to end up with a reasonably balanced bill. The big issue for CBO is going to be, is the bill deficit neutral? Does it bend the cost curve, look like it's going to reduce health care costs in the out years? How many uninsured is it actually going to cover, and what are the costs going to look like? I would be very surprised if some huge number comes back and they have to go back to the drawing board on major pieces of this bill, but I've been surprised before. So,
George from Slidell, Louisiana, with Maria Fries. Good morning on the Democrats line.
Yes, good morning, and thank you for taking my call. I'm a very long-time listener and first-time caller. And I guess my question is, from all I've been hearing, it's going to take a long time for this buy-in to Medicare to even come into effect. And what happens in the interim? I'm 58. I was laid off after being employed most of my life. I've had to go into my 401k plan. I haven't been able to find a job. I'm not stupid. And I just, what happens to the people who fall through the cracks?
well, there are a lot of people that are falling through the cracks today, and I think depending on which pieces the ultimate bill picks up from, the House bill, I believe, had an insurance pool that people without insurance who were in your roughly in your age range could purchase into. Many of the Medicaid changes will be phased in fairly quickly. So if you're low income, you may be able to get assistance that way more quickly than you would if nothing happens at all. That's the other thing to keep in mind. If this bill goes down and it doesn't end up being signed into law, my expectation is it'll be a very long time before you're looking at major health reform again. So things aren't going to get any better for people who are currently without coverage or unable to afford their coverage.
Michael is twittering this question. Can Ms. Fries explain why health care providers should continue to provide service at a cost below the government plan?
Well, Medicare right now pays providers less than private insurance does. That's part of the reason why it grows in costs more slowly than cost in the private sector. Roughly, it pays hospitals about 70% of what private insurers pay, and it pays doctors about 80%. And clearly those providers have decided that that differential is acceptable to them because, for the most part, seniors don't report a lot of access problems. You have pockets of them in places, but you're really not talking about major problems with seniors being able to see doctors of their choices, going to the hospital of their choice, having long delays. So the differential that exists in the current system is obviously one that the system has adapted to. That's one of the reasons we're so determined to have these changes done in the context of health reform, because that differential should stay the same. If all of healthcare costs are slowing, then the difference between what Medicare pay and what the private sector will pay should stay roughly what it is today. And there are a lot of reasons why providers are willing to take that differential. They're still making money. And it does end up, the Medicare program is a lot easier for them to deal with administratively. At least prior to the privatization, you had one set of forms, you had one set of rules to follow, you got reimbursed fairly quickly. It was a much more administratively simple program to work with. And so it was worth it for them to take a little bit less money because they made up for it by not having the cost associated with all these private companies.